Good afternoon, everybody, and welcome to this, the last of the CHF talks for 2021. As you've probably realised, I'm not Leanne Wells. I'm Jo Root, the Policy Director for CHF. Leanne has caught up with some family issues this morning and will join us as soon as she can. I'm sure we all hope that that everything's okay with her mum. So, thank you for all joining us today. I'd like to start by acknowledging the traditional owners of all the lands that we're meeting on and acknowledge their continuing custodianship of our land, sea and waters here in Australia. I'm on the lands of the Ngunnawal and Ngambri people here in Canberra, and I'd like to pay my respects to their elders past, present and emerging, and also pay respects to any Aboriginal person here with us today. It's always very important to make an acknowledgement of country and traditional owners when we're dealing about health, because we all know about the health inequities that our First Nations people have, and that everything we do needs to be designed to overcome that inequity. So thank you again. Today's webinar on Reimagining Healthcare, I think is going to be a really great presentation and discussion with panelists. The first part, the webinar will be in two parts. The first part will be a presentation by Suzanne Robinson and Richard Norman, who are both from Curtin University, and they're going to present on their findings from a study they recently completed in partnership with CHF, with funding from the Digital Health CRC and the Australian Government Department of Health. Suzanne is known to many of you because she has presented for us before. Suzanne is the lead for the Health Economics and Data Analysis discipline at Curtin University and co-director of the Curtin Research and Data Analytics Hub. Suzanne has demonstrated that she's passionate about using evidence to support the delivery of effective and equitable health services. She also is a really good partner with consumers, and she recognises and doesn't just talk it but walks the involving consumers in health research, policy and practice, and has worked with Consumer Health Forum in research and advocacy work. Richard is a health economist with ongoing interest in the economic evaluation of healthcare, the measurement and evaluation of quality of life, and discrete choice experiments. He's an associate editor of Value in Health and is a permanent member of the Economics Subcommittee of the Pharmaceutical Benefits Advisory Committee. There is more about both Suzanne and Richard in the invitation. So without any more ado, Suzanne, I'm going to hand over to you to present your really exciting research results, and then we'll go to the panel discussion. So over to you.
Thank you, Jo. That's a really kind introduction. And I'm just checking that people can see my screen. I'm just trying to share it as a, can you see that?
Yep, we can.
Okay, so thanks everyone, and it's really great to be here again this morning. Sorry, it's a bit early in the West, and I feel that I need a bit more coffee, so hopefully my voice will hold up. And if I do have a drink, it's just to keep the voice going. I'd also like to acknowledge the traditional owners of the land on which we meet, and for me over in Perth, it's the Wurundjeri people of the Noongar Nation. And I'd like to extend my respects to Aboriginal elders, past, present, emerging, and any Aboriginal or Indigenous and Torres Strait Islanders we may have in our presence today. So, like Jo, I think that's a very important thing that we do as we present at these forums. Now, I'm going to see if technology works for me, because Richard unfortunately can't be here. Well, fortunately for him, because he's actually on holiday. But I'm going to flick to the slides and see if the recording works. If it doesn't work, then I can talk to the slides, given that the studies are work that we've both been involved in. And so I won't babble on about anything else. So I will flick to the slide and let's see what happens. But I will have to do a sound check to make sure that people can hear.
Hi everybody.
Can you hear?
Thank you for the opportunity to present in this forum, and I apologise for not being able to be there in person. So today I'll be presenting.
Are you able to turn it up at all, Suzanne?
Examining consumer preferences and experiences regarding telehealth and embedding the consumer into reimagining healthcare in Australia. And I'd like to acknowledge our partners and the commissioning from the Australian Federal government Department of Health. So the purpose of the study was to identify the determinants that influence consumers' preferences, experiences and attitudes towards telehealth. And it took a few strands, both a qualitative one and a more quantitative one. And the two studies were these. The first study was something called a kitchen table discussion, which is a novel qualitative approach involving health consumers as the central part, both as subjects but also as facilitators of the project. And I'll talk you through the methods for that in the next few slides. The second study was something called a discrete choice experiment, which is a general approach which aims to identify how people value different aspects of a good or service. So it's a survey, and we ran this big survey online using a general population sample. The two sub-studies are fundamentally linked. So the outputs from the kitchen table discussion feed directly into the design of the discrete choice experiment. So I'll present them in that order. So the kitchen table discussions are fundamentally focus groups, but they're conducted in a very particular way. So what we did was we used our consumer health forum networks, and I thank the CHF for giving us access to those networks to recruit hosts. Those hosts are consumers, and they receive Zoom training, they receive a comprehensive host guide, some probe questions and feedback templates. And rather than the researchers conducting the focus groups, rather it was these hosts who actually were trained to run and evaluate the responses of respondents in the focus groups or the kitchen table discussions. In this particular study, we recruited 90 participants from the hosts' networks, and the hosts conducted semi-structured focus groups, 60% of which were face-to-face. One of the great advantages of this approach is that it allows access to groups of quite specific subpopulations who might have different views about telehealth. So, for instance, we had one condition-specific group made up of people with kidney disease, and we had one made up of native Japanese speakers, a group who we would not have been able to access if it weren't for the kitchen table discussion nature of the qualitative work. We also wanted to ensure that we had a nice spread of geography, and we were pleased to see that 2 of the sessions were held in outer regional areas in WA and in New South Wales. The results from the kitchen table discussion are presented here, and we basically identified 8 key themes in the analysis, which are given in the outer ring of the circle. And you can see, for instance, that many people raised issues around access, around connectivity, having an existing relationship with the doctor, and so on. And interestingly, in each of the 8 subdomains, there were people who felt that virtual care was superior in that regard, but also people who thought it was inferior in that regard relative to face-to-face services. The discrete choice experiment took those results and used them in a large general population survey. So the discrete choice experiment is, as I said, a survey. It's a quantitative study which is aiming to explore how people value different aspects of their primary care consultation. I'll give an example on the next slide, but the fundamental principle is that we present respondents with pairs of options for care. So sometimes face-to-face doctor contact, sometimes a telephone call, sometimes a video call, and ask them to pick which one they would pick if they had to make such a decision. One of the things that came out of the qualitative work was that we identified that people felt that they were more or less likely to take up virtual care based on the type of healthcare consult that they needed at that particular time. So we did present 3 possible clinical scenarios to different respondents. So sometimes we asked them to imagine they were seeking a repeat prescription. Sometimes they had a new and unknown physical symptom, and sometimes they were seeking care for a post-surgical follow-up. Each respondent answered 10 of these hypothetical tasks, and we pooled all of the data to explore what on average drives that choice of choice between different primary care consultations. We administered the survey in a general population panel of 1,000, and we ensured that 1,000 people were population representative in terms of age and gender. So here's an example of a discrete choice experiment task. In each task, we changed everything. So sometimes option A was more expensive, sometimes option B was more expensive, and so on. We asked the respondent to imagine they needed a repeat prescription for a condition that they have, and they needed to see a GP. You can see here there are two options. One is a video call, one is an in-person consultation. And you can see that each option has a variety of characteristics that might make it more or less attractive to the respondent. Okay, so the results from the discrete choice experiment are now going to be presented. The sample consisted of 1,025 people, and as I said, we ensured that they were representative on age and gender, but we were also pleased to see that they were largely population representative in terms of country of birth and primary language as well. Our sample was slightly better educated than the general population, so you can see, for instance, that the proportion of people with bachelor degrees or higher degrees, summing to 45%, is above the level of the general population. Interestingly, the sample had some experience of telehealth and video health, with 56% of people having used telehealth in the past 5 years, and just approximately 17% having used video health. And just to flag the education levels. So these are the results. We use something called a conditional logit regression, which isn't important to dig into the details, but what's important to look at is the numbers and the sign of the numbers, whether they're negative or positive. So in each of the dimensions, which are listed down the left-hand side of the table, you can see that one of the levels is defined as the reference level. So everything should be considered relative to that reference level. So for instance, if we're talking about how the individual talks with the GP, in person with a 5 kilometre travel is the reference level. Everything else is negative in that dimension. So the top 5 numbers on the right-hand side are all negative, suggesting that they're all less attractive than that in-person consult with a 5 kilometre travel distance. So a lot of the results are unsurprising. So the average preference in the population was for face-to-face consultation. They wanted to be familiar with their GP. They wanted the GP to have good access to medical history. They wanted less waiting time, opportunities to ask questions, and a cheaper price. What struck us as interesting is that our respondents were very price sensitive. So even though virtual care, all other things being equal, was seen as less good than in-person care, if virtual care were to be provided at a lower out-of-pocket cost, then the results suggest it becomes an attractive option. Okay, so the results from the previous slide reported average preferences, but we ran an additional analysis called a latent class analysis, which breaks down the sample into groups. And here we identified 4 distinct groups of respondents. So Class 1, which was about a third of the sample, had quite balanced preferences, which was similar to the results I showed you on the previous slide. Preference for a low-cost consultation with a familiar doctor in a face-to-face setting. Class 2, which was slightly larger at just under 35%, were very price sensitive. So everything, they always picked options which had the lower cost. Now other dimensions did matter, but cost was the consistent predictor of choice. Class 3 had a strong face-to-face preference and was 16%, very little appetite for virtual care, and they basically never picked it when faced with the in-choice tasks. And Class 4 provided some disordered preferences, hard to interpret, which to me was suggestive of poor engagement with the survey. But we still got good engagement with the remaining 84%. Interestingly, of those who did provide plausible preferences, i.e. classes 1 to 3, only 20% were strongly averse to telehealth. So I do think there is a willingness to engage with it if it provides services in a way that is otherwise attractive to participants. Okay, so last slide, a few key research findings from this part of the study. It's clear to me that one size doesn't fit all. So there are significant differences in preferences across the population, meaning that multiple modes of health service delivery will be needed in future if we're going to have a fully patient-centric healthcare system. One thing that came out of the kitchen table discussions for me was that whilst telehealth is a simple mode of communication, its implementation is very complex. So embedding it within current systems, current relationships with doctors can be very challenging. In the discrete choice experiment, there did seem to be some differences in rural and remote consumer preferences. They weren't large, but it did suggest there were some differences, and we have to treat rural and remote patients somewhat differently. On average, across the entire population, face-to-face was preferred over virtual care. However, I think one of the key things that came out of the study was that most respondents were highly price sensitive. And if the out-of-pockets differed between the two modes of administration, then virtual care becomes quite an attractive option. Finally, telephone did seem to be slightly preferred over video in both the kitchen table discussion and the DCE. I'm not sure if that'll change as exposure to video increases, but that's something certainly to keep an eye on over the coming years. Thank you for listening, and I'll hand back over to Suzanne.
Thanks to Richard for that presentation. It was really clear. And now what I'm going to do is present you a short presentation on another piece of research that we've been involved in with CHF again, so with Consumer Health Forum and Deloitte. Were partners along with Curtin University and the Digital Health CRC who funded the project, and I've also been involved in some of the development of the project. So this project aimed to better understand consumer attitudes, experience and preferences. It's very similar to the previous project, but it was a bit broader in that its focus was around virtual care more broadly. Had some telehealth questions. It was a survey that we designed, had some telehealth questions in the survey, but it's a focus that's much broader in terms of not just about telehealth. So I'll get on to a little bit of the methods. So the methods and the design process. We actually have undertaken this project a rapid review. We had a large webinar. We had a participant survey, so participants in the Digital Health CRC, so all the industry, any non-university health providers, tech partners. We did a participant survey, and from that survey, we gleaned some results that we then put together with the webinar and the rapid review. And we put all that together, and we had a little look around and found a survey that Deloitte had also implemented around virtual care. And we came up with a survey that we wanted to test with our consumers. So we had a consumer pilot, we tested the survey, and then we rolled out, which is quite a large survey in terms of questions, it was around 48 questions. And so we rolled out that survey to national survey through different channels. The key themes, there's lots of questions, I said, so 48 questions, so it's a large survey, but we did have a good response rate in terms of the quality and a few missing data points. So we're quite pleased in the end result. But here are the key themes. I won't read each of them in turn, I'll just give you a second to familiarise yourself with those themes. Sitting underneath each of those themes were a series of questions. So we had some questions about telehealth, but then we also had questions that were about information sharing, about people's current use of technology, and about their opinions, what a future world of health might look like. And in terms of response rates, we did actually go out through what we call the Australian Health Panel, if that might be familiar to a few of you. For that particular outlet, we split the survey into two because we thought it might be a little bit large. So we did survey one, which was very much focused around some of the telehealth questions and a couple of others. And then we had survey two, which is much broader. And you can see the numbers there in terms of how many people responded. And then we also went out, if you work along the slide, we also went out to what we call the national survey rollout, which was through the networks of all of the partner organisations. So all the partner organisations have extensive networks. So we pushed out, and we did quite well in terms of it being an electronic survey. We did quite well in terms of a response across the Australian Health Panel and the national survey rollout. We had a look at that data, and we were a bit concerned that we had a bias around education. So the education, people's educational attainment from that sample from both avenues was very much people who had a bachelor degree or above. And we were concerned that that might bias our overall findings. So we decided to recruit an online market research company that we use quite a lot for surveys. And we asked them to only allow people to take the survey if they didn't have a bachelor's degree. So that changed the results somewhat, and I'll come on to that in a second. But as you can see, the completed the remaining, so the surveys that we could use that were generally of high quality were 1,826. I say high quality in that they were completed more or less fully. So we have 1,826 participants from across Australia. Here's some of the characteristics. So of that 1,826, we got 60% were female, 20% were aged 66 years and above, 65% in major cities, and 63% reported good or excellent health. And 32% had a bachelor's degree or above. So we've managed to get that number down, as it was very skewed. It was around 70-something%, I think, maybe even higher than that. So experience of telehealth consult in the past 12 months, we asked people what their experience was like. They were generally, in terms of telehealth, satisfied. So 69%, 70% were equally satisfied with telehealth, and 27% said they were more satisfied with telehealth over face-to-face. The telehealth questions were the first bit of the questionnaire. Further use, 60% would like to continue using telehealth for healthcare needs, and 70% would recommend telehealth to others. And I always think that's an important question to ask if you'd recommend to family and friends. In terms of, I think this is important, in terms of experience of telehealth in the past 12 months, 17.4% experienced technical difficulties. That's quite important, because that means that people were having technical difficulties, which we would assume would impact on the quality of that consult. And 16.5% said technical quality affected the consult. So you can see that it did affect. Efficiency, 79% said they saved a lot of time using telehealth over face-to-face. And that came through in the kitchen table discussions that on a previous study, and also in the discrete choice, the importance often of efficiency savings for patients. Experiences, we've had a lot on telehealth, so it's just a couple of the questions I've talked about, but the take-home messages for me was there was no real significant differences from metro and regional remote populations. So Richard said there were slight differences in the DCE. We didn't really find that in terms of use and satisfaction in this survey. What we did find, and this is really important, and we're so pleased that we pushed out to get that balance, is that education and background matters. A bachelor's degree or above was associated with higher use of telehealth, and the lower economic attainment, the less satisfied or less likely people were to use telehealth. There's about 20% of people who generally don't want to use technology, and they tend to not have a bachelor's degree, and we'll come on to that in a second or two. So I think it's really important to hang on to that thought around how education matters. So the broader questions then about willingness to use technology to support one's own health, the question we've got here was around the proportion that reported they have access to digital technologies to support. And you can see the different levels, and that smartphones and tablets, apps, 63.8%, so 64% are actually accessing smartphones, so have access to it. That's quite a large percentage of the population. However, on the flip side of that, 30% don't have. So I think we have to consider that going forward. And you can see the different levels, and that 21% have none of the above. And this came through in this survey, but also in the DCE. There's about 20% of people that don't want to go down a world of virtual technology in terms of their healthcare. And that sort of aligns with that could potentially be people who just don't have access, they just don't want to have access generally in broader life. I thought I'd pop this slide in because we hear lots of talk about navigators and coaches and the importance of that. And we asked people's willingness to access this type of activity, so type of technology, if you want to call it technology. And you can see that we had very willing, or somewhat willing, and that's a total. So these are all, if you add those together, there's quite a lot of people that are willing to access a health coach and access a digital navigator. So we're seeing that there's lots of interest or potential, at least willing to engage with those types of activities. Willingness and ability to use one's technology again, so proportion willing to adopt a technology for different purposes. We asked around, what sort of purposes would these be? We had measurement, fitness, health and improvement goals, and we've got, just over half of the participants said there would be. Order a repeat prescription. people at 60%, 60 or 61% if you round up, are willing to engage with that repeat prescription supply. So potentially you could have a telehealth consult and then you could have your prescription and repeat prescriptions thereafter. So you can see how those models might develop, and we had 60% of people interested in that. Main reasons for the unwillingness to use technology, we had 18% of people just didn't feel it was necessary. That was the highest percentage, and people didn't feel it applied to them. And there's this also a feeling of being uncomfortable with the use of technology that's not known to them. The next area of interest, or one of our areas, was around your willingness for people to share information. We often hear that people aren't, we hear from clinicians, from data custodians, that people aren't willing to share their own information in health. And that sometimes can be a blocker for people like myself as a researcher actually accessing information, but it can also be a blocker for the health services being able to share information. In our survey, 95% were comfortable or somewhat comfortable sharing information with healthcare providers. 90% were willing to share information tracked in their apps, devices with the general practitioner to assess future risks of becoming unwell. And 90% said they were interested in being able to access their own health records, to share their health information, send messages to their healthcare team, or edit their care plans using their personal device. That's a very high percentage of the sample that we're willing to do that. So, I mean, that's very positive as we move forward with technology. The places people are willing to share information from their own medical records. So who are they willing to share information with? And as I sit in a university setting today, it's quite nice to see that the participants were generally quite willing to share with universities and research organisations. Also, willing to share with government organisations and other government agencies, which I think is good. Professional medical bodies, pretty high percentage there. And as you can see, the percentages go down as we get for the private for-profit health businesses. So there's a bit more of a reluctance, although some people are willing to, and then non-government and advocacy health groups. And I think this needs a little bit more unpacking, but I think it's positive in terms of people's willingness to share with a broader group. And of course, we often share information using our Apple and other things quite a lot in our day-to-day life. So it's always interesting about what we're willing to share in health. Willingness to adopt alternative methods of care. This is another question. Of the 15 proposed alternative methods, so what we did was, in the survey, we had some scenarios about different alternative methods of care, and we were thinking about what the future reimagined health state might look like. We had a number of different scenarios, and some of which are listed here. At least somewhat willing to use monitoring devices to manage their long-term chronic illness, so a monitoring device to monitor their illness to alert them and their health provider if they needed to attend hospital. Again, a high percentage, 80%, that's a high percent. At least somewhat willing to use monitoring devices as a caregiver, so not just for themselves, but for someone else. We had, again, around 80%. At least somewhat confident in managing their chronic disease. You see the confidence slips a little, so people are willing, but the confidence goes down. It's only a small percentage, but it's worth noting, I think. And then at least somewhat confident, it slips a little bit more, like 1%, but you can see there's a slight difference in that percentage. And again, I think that would probably need to be thought through in terms of people's confidence to be able to manage themselves, their own care, or that of their loved ones. And take-home messages from this survey then. 80% of the population are willing to readily use digital technology. That's a high percentage. But it does suggest that 20% of the population currently, from this survey at least, aren't willing to use. And I think that's really important. And that's important for us to unpack and explore. What we don't want to do is have a digital divide as well as potentially a health divide. And that links to the next question, the next point here, around education and background matters. What it does seem from a look at the data is that 20% of people that are unwilling, what we can see, tended to have a low a low educational attainment. And the lower the educational attainment, the less likely they were to want to access or play or work with or use digital technology. I think we really need to understand this a little bit more, and we can't really necessarily do that from a survey, but it is something worthy of exploration. Because for me, if that's the population who, with a lower degree, potentially could also be population with with some of our most vulnerable communities, with health issues, etc., we could be making the equity aspect even wider in terms of the gap between certain groups of people. So I think that's worthy of an exploration. Ongoing measurement of the implementation of effectiveness and cost effective of digital technologies. I think we need to look at not only the effectiveness, but also the cost effectiveness. And I think we need to look at how we implement. So you can see that coming through with the confidence of our consumers. We need to make sure that we implement in a way that allows confidence. And there's the work that Richard talked about, that one size doesn't fit all. I think that just comes through time and time again. So we're thinking about implementation. We need to be considering how we do that for complex patients in a complex system. Given the COVID-19 pandemic is likely to continue, unfortunately, I don't know when the end is in sight, but it does seem that that's going to continue to roll along with us. And we have to, we hear that from the government, we have to sort of get on and live with life with COVID. Then we really do need to think about redoing these types of surveys to see how the use of technology may be increasing, decreasing, and what's happening to our consumers as they go on the journey with technology in times that have been different than pre-COVID or pre-pandemic times. I think the findings from this study and others can be used to refine the conditions under which governments start to normalise digital platforms. And when I say normalise that, I'm not suggesting that digital should take over and we don't have face-to-face. That's not at all what I'm saying. It's how do we integrate technology into existing or new models of care that include our clinicians and our consumers making joint decisions about their healthcare. And I'm keen to stop there. The survey is large, and it's always hard to pick which questions to explore. But we have got an expert panel, and there's some great people on the panel who would want to dive into this and also have some great knowledge and experience to share with us. So I'd pause there, and I will stop sharing my slides, and then hand over. I think we've got Leon back. Is that right?
I'm back, yes, and just to your thank you. To your last point, Suzanne, we've got to learn to live with COVID. I was late because I unexpectedly had to take my mum off for a COVID test and the queue was very long, so apologies. Thanks to our panellists, and I'm assuming Jo introduced our panellists, or do we need to do that now?
She did introduce, oh no, she's not introduced. Did she introduce the panelists? She didn't. No, she introduced herself. So she did a great job of introducing me, but we'll hand over to you to do the panelists.
Okay, so to introduce our panelists, we've got very, very expert people in this topic. We've got Amanda Cattermole, who many of you would know, if not all, CEO of the Australian Digital Health Agency, Professor Tim Shaw, Professor of eHealth at Sydney University. That's right, isn't it, Tim? Yeah, we've got Layla Hallam, a consumer advocate, very active consumer advocate from New South Wales with a strong interest in telehealth. And finally, but not by any means least, Dr. Amandeep Hansra, who is coming to us from Fiji this morning, I know. So I think you seem to have tested okay, Amandeep, so we're not expecting you to drop out. So I would like to ask each of our panellists, I mean, it's a big, rich data set, and we'll come to the reports and publications that'll be available from the two studies as we close off the meeting. But there's several key takeout messages there. Education matters. The high levels of willingness to engage in alternative or digitally enabled models of care. I think it's really promising, but the caution around digital divide is clearly a signal to us as well. So I might actually start with you, Layla, first. I'll ask each of you the same question, and to comment on that is, what were your overall takeouts? What really stood out to you in your sphere and in your world about the results that Suzanne presented? So starting with you, Layla.
I thought the results were pretty much in line with some of the work that's been happening with in New South Wales as well. So I think that's fantastic. The more aligned we are with the feedback that we're hearing, the better, the stronger we know that the research is. So I think that's fantastic. There were lots of things we actually aligned with, and that includes the things like willingness to share information and being service specific. So we talked about, I'm happy to do e-meds, for instance. I'm happy to get a repeat prescription, but I'm a bit more cautious about diagnosis, for instance. But I think that's actually part of the richness of how we move forward, because it's the nuance that's going to be really important from here on, I think. I think the first thing I would say with regards to the 80% who are willing and ready to go, I think we should be a little bit careful with that, because that 80% may not be the people who need it most. So they may not necessarily be the people who will be the repeat users and who are continually coming in. So I think that's one thing I would be a little bit cautious with. I'd also say there's a really strong willingness and ready to use amongst those people who do need it the most. So those people who are pretty well into their health management, so they have conditions, they're living with illnesses, and they are well into their health management. So those that are a higher level of managing themselves, for them, telehealth will absolutely, they will see the value and they will really understand how to use it. And I think that's probably a really good place to start. But there will be others who are maybe earlier on in their illness or condition, and for a variety of reasons, whether they're open to their technology, whether it's because access to technology is a problem, let alone their confidence in actually using it, before we even get into, you know, how it can be used. I think the research is exactly online, but I think now is the opportunity really to seize what we do know and really delve in a bit deeper. That's probably my biggest takeout. I think it's fabulous. Well done.
Yeah, thanks, Layla. Over to you, Amanda. I mean, just to Layla's point about it's about implementation. Your agency's currently leading and will be stewarding both the development of a new national digital health strategy for Australia and oversighting and stewarding its implementation. So what are your takeouts, particularly in the context of the line of travel that our next national digital health strategy should take?
Thanks so much, Leanne. And thank you to Suzanne, Richard and the teams. It is just fantastic research. And I had exactly the same reaction as Layla, which is fascinating to see that growing consistency, because you're right, it then really tells us something about the signals we're getting and how we work and respond. So we are getting quite similar messaging through our consultation process on the National Digital Health Strategy. Very, really strong changes in that willingness, that sense of wanting to engage in digital health technology, and even really interestingly, even in the engagement itself. So if you just think about one stat, which is more about process than content, but I think it was so interesting. When we ran the consultations of the first National Digital Health Strategy in 2017, and if you just think about the 4 years and a bit we've had since then, about 600 consumers responded. This time round, 7,500 is where we're up to now. So there's that even in itself says something really powerful about Australians' engagement in this, and then they're saying very similar things to the things that both Suzanne and then Richard and Layla all indicated. So I think that consistency and that sense of growing confidence and feeling like they can influence, I think that is really powerful and a big shift. And I noticed in the chat a few of our participants rightly calling out one of the new challenges, which is a real flip, I think, is consumers are now driving the call for, I want to see my records, I want to see that information, and frustrated on many occasions that their GPs and other health providers aren't always putting it into their electronic health records, including obviously the one that we support, the My Health Record. And so there's this a strong sense of drive now coming from Australians, and that's been accelerated, of course, by our experience of the last 18 months. And we have seen just exponential change in people's engagement with their My Health Record, just off the scale. I mean, just to take one, the increase in people's views of their immunisation information and COVID certificates, 930%, 500% on pathology, and so on and so forth. It is, so there's this step in that we've all had. That's one piece for me, absolutely critical, and consumers can now stand deeply at the centre of this conversation, and I think that is so powerful. And obviously, people around this table deeply helping to drive that, and I think that's fantastic. The second takeout is also the one that came up in both the sets of research around, amongst that though, there's flags about who and how, and we need to really pay attention to that. And I think even on that connectivity question, and that some of us have had conversations about this before, there's nuances around what that means.
Yeah.
And I think we need to get very clear and really test that proposition around those feeling unwilling, unconfident, or perhaps unable to access. What does that really look like, and how do we make sure that the interventions and support we provide are very targeted, so that there's not only about confidence, but about connectivity and about the kind of information that people are wanting to engage with or not, and why. And so I'm very quite attracted to that navigation conversation. I think there's a lot in that. I thought it was really interesting coming out, but I think there's a lot of work to do together on those flags around those feeling either unconfident or unwilling, and how we provide the support that will assist them really in a really targeted way, and also make sure that we don't close off channels that others will need. This has got to be a multi-pronged story.
Thanks, Amanda. And it's interesting, the point you make. Well, it's not interesting. It's almost like common sense, isn't it? That once something like My Health Record can demonstrate its utility, as it has done, as you say, with COVID vaccine certificates and vaccination records, it does drive that demand. Once the utility is demonstrated in people's everyday lives, just like clinicians with their everyday workflow, that's when the take up really starts to happen. Tim, your thoughts and comments?
Yeah, look, I thought it was really interesting results, as others have said. I guess what it says to me is that I think we're a bit of a tipping point at the moment in digital health and impact on consumers. So I think what it actually shows is that consumers are actually probably willing, or many consumers are willing, to go further than the actual health system is willing to change itself. Because when I see this, I think there's a real inertia in the health system to do anything more than just replicate the same model of care we've used all along by swapping out a face-to-face consultation with a telephone call, rather than really unpacking how we work with consumers to put them in the center, and as we've said before, reimagine how we deliver that care. Because I think the danger is at the moment that we're just kind of swapping out tech and still keeping that same model. I mean, even for somebody like myself, who's highly educated and connected, I have cardiovascular disease, atrial fibrillation, so does my mother. Nobody sat down with us and said, okay, Tim, how do we reconstruct how we wrap this technology around you in terms of using virtual navigators, accessing your data, looking at you longitudinally? My mum's got mild cognitive impairment. How does that impact? How do we handle all of that? All we're doing is exactly the same thing. I still see my cardiologist once a year, have no contact with her between visits. She sends faxes still to my GP, no attempt to manage any of this. So to me, this is a clarion call, and because obviously it's always inertia in healthcare to change. We know that it's a conservative business, but the fact that we've got these data saying that consumers are willing to change, so now we have to look at how we do that, and we move away from that paternalistic model of healthcare that we have, which is the control by the health professional, to a consumer-centered one where we put the consumer in there and say, how do we do that? Obviously, with the caveats like Amanda and others have said, that that there's a significant percentage here that of 20% that aren't willing, and then lower education. I love George's comments about fund less doctors and fund more teachers, because I mean, clearly, we have to understand how we educate and bring the health, the community with us as we do this, and make sure we float all the boats and not just the boats in Mosman and Toorak, so to speak. We've got to bring everybody along with that and do that. But I just think this is enormously exciting. I was on the RPA virtual research seminar yesterday for RPA virtual to be doing a lot of this work, and you can just feel this energy in the room now to say, okay, we've got this. How do we lift this forward? If all we end up with is an MBS item for telehealth, then we failed. I mean, that's a huge, important piece of the puzzle, but we failed if all we do is just fund a little bit of swap out of technology.
Thanks, Tim. And you've got comments there saying you are so correct with your observations. Over to you, Amandeep, and I think you absolutely are right. I mean, it was a great announcement yesterday that we got the telehealth permanently subsidised under Medicare. Everyone's been asking for that. We've been lobbying for that. Amandeep, over to you for your reflections and comments.
Yeah, look, I'm probably going to echo what most people have said already, in that the research findings were incredibly powerful. I mean, not unexpected. I've always been of the belief that it's not our patients that are the problem, and I think a lot of the time my peers, myself included, have been very quick to say our patients aren't ready, but I actually think that the patients are more ready than we are in many ways. And I think the comment, one size does not fit all, is a really important one. We've got to understand that our patient base is very diverse. People have differing levels of, as we've noticed, digital health literacy, connectivity, access to devices, education, and we as healthcare providers should be catering to all of those needs. So if people want to see us face to face, they should be able to. If people want to see us via telehealth, they should be able to. So I think it's really about offering choice, and we have an obligation, I think, as a medical workforce, to use whatever tools we have available to give patients access to healthcare. And we've had the telephone for a long, long time. And I agree with you, Leanne. I was doing a little dance when I saw the announcement on Monday about permanent telehealth funding. And then I was quite embarrassed that I was celebrating something that I've been doing for 10 years, you know, talking to patients on the phone. And yes, we've done 86 million consultations in the last year and a half during COVID, but 97% of them have been over the phone. That's not exactly innovative and, you know, a revolution. But what it is it's a sign to say we need to start moving the conversation. And as per Tim, you know, this needs to be beyond, let's switch out a face-to-face for a phone call. This has to be, how do we involve, you know, sort of asynchronous messaging? How do we connect with our patients, you know, whether it's by email, whether it's through apps? How do we use remote patient monitoring? Like, there's so many opportunities out there for us to provide better healthcare to our patients by using the technology that's there. And I think for a long time, we have kind of buried our head in the sand about it. And now we don't have that choice any longer because of COVID. But I want to say, just, you know, to defend the GPs a little bit that might feel a little bit battered by some of the comments I'm making, it's been a difficult time for us. There's been a lot of change fatigue, as you can imagine. And it was very hard without certainty around funding to set up infrastructure adequately, to invest in infrastructure, to invest in change in workflow, when every time we got an announcement, it was the funding is another 6 months, another few months. So finally, we've got the message that this is here to stay. And now we can properly invest in, whether it's new models of care, whether it's getting webcams that people have mentioned on here, whether it's setting up processes for our patients, you know, in choice, how they want to access us. There's just so much work that can now be sort of commence because we have a bit of certainty. So I think we can be happy about the announcement, but I think we absolutely need to be listening to our patients, consumers, and giving them choice and listening to how they want to access healthcare. I might stop there.
You're right. And the announcement, I agree, was very much a first instalment. We've got lots and lots of questions. And I think you've all made the point about patients not being the problem, that they're more ready than we think, and the research underscores that. They're certainly more ready than the workforce. And this is not to be critical of the workforce, but if change is to happen, there's quite a few questions in here, you know, talking about how can we get GPs to upload to My Health Record. That's quite a specific question around My Health Record, but how can we get clinicians to adopt and embrace digital modes or digitally enabled modes or enhancements to models of care more generally? That strikes me, I don't know whether it's too strong a word to use, but it strikes me as being a bit of our wicked problem. What are your thoughts on that as a panel? Tim, did you want to go?
Yeah. So how do we get clinicians to adopt different models of care? I mean, look, it's obviously a huge challenge, and it's a complex issue. I mean, it has obviously funding aspects to it as well. But I actually think we need a kind of a bottom down and a top down, bottom up approach. And I think some governments are starting to to really look at this. So for instance, in New South Wales, they've got the collaborative commissioning work that's going forward, where they're actually working to work with acute care services and primary care services to look at how they can reimagine care for populations. And I think we kind of have to do this, because one of the great fractures we obviously have in our society, which is totally artificial, if you go live in the States or the UK, this break between our primary acute care services is kind of fundamental to changing some of how we do this. So I think we need government to kind of support initiatives where we can start to kind of reimagine how we do that. So like in Murrumbidgee, they're looking at how they can manage people with COPD across the spectrum of socioeconomic education, cultural diversity, and so on. In Western Sydney, they're looking at how they can manage people, ironically with AF, I'm on the project, but in different atrial fibrillation in different ways, because then you can bring all the parties together to say, okay, what does it look like? So you can have GPs in the room with the cardiac specialists. And I've been in these meetings where it's still staggering how lack of understanding there is between, say, general practitioners and specialists about how they can actually manage the care of those patients, and then how do you put technology around that in an envelope. So I think if we do it carefully and move like that, then everybody's part of the conversation and the consumers are in the room too. So then you can come up with like, okay, this is how we're going to do it. So if you're discharged from Westmead Hospital, for instance, you'll have technology that wraps around you, gets you to the GP, monitors your health. The GP has better communication channels with specialist services, so we don't get these kind of breaks and fractures happening, and we understand how the data can work. So I personally think we need a lot more initiatives like that, where we have the federal, state, primary care, acute care, and consumers working together to design these and demonstrate value. I think it's one of the hard problems of My Health Record has been to demonstrate that real return on investment and value. So I think we need more of these projects that show that.
Sorry, Amanda.
Yeah, no, I was just going to just given that Tim's said the My Health Record bit. So I totally agree with Tim. I think it's obviously drawing on all those meta levers and bringing practitioners and consumers together, and that system, engaging across the system. The other bit, though, it's almost like writ large and sort of writ small, if you like, because the point that Amandeep makes around just how much, GPs and other health providers have been managing over the last 18 months, it is then difficult, as you say, to make all of that structural change that is needed while managing just the kind of extraordinary things everyone's been working on in the last 18 months. So part of what I think, we've all got bits of this story, and a bit we've got is twofold. One is helping that back-end infrastructure be as useful, contemporary, and engaged in clinical information systems as it can be, so that those workflows are available in a way that is going to support GPs and others while they're engaging in patients. So for us to do that work, to make it as seamless as possible and provide that information when it's needed. And the second one is for us to continue to grow that utility. That's exactly right. And I think, Leanne, you touched on it too. For us, the more that we make changes that are exactly what Australians need when they need it, the more they'll engage, the more that it grows that virtuous circle. And so I think for us to try and do that while those other things, meta things, are happening, we all then add little pieces to this story, which I think is absolutely at a tipping point. And it's incumbent on us to do everything we can that is going to keep that charge driving forward.
I was going to say, we also need to start to take a bit more risk in health. I don't mean risk with people's health necessarily, but we're very risk averse. And if you want innovations, you have to take some risk. And I just think we need to have a system that allows that, obviously with safety. And the other bit for me, which is slightly different, I agree with what everyone's saying, but the other bit to add to that would be about how we procure, because our procurement processes are so difficult. It's very hard to be agile and to be able to procure quickly and get very responsive. And we could do that during COVID because we had a pandemic, but the rest of the time, if it's business as usual, we just can't procure things in a way that we'd really want to. I'll let
I think Layla, did you have something you wanted to add there, Layla?
I was just going to say, for me, there's two parts to that. One is really embracing that whole learning. I was going to say organisation, but I actually want to go much broader than that. I want to go learning system, so that what we're actually doing is, so all the organisations at the moment are learning within their organisations. I think now is the opportunity to really look at all the best practice and look at, the champions and who are doing it really well, and take the lessons and then really disperse them, which is something New South Wales is really trying very hard to do, but it's a really hard thing to do. So I think as much as we can get into gear about trying to harmonise, so in New South Wales, it's about, going across the services and then going, with the GPs and going across care, for instance, community care in the community. So it's trying to get that, but it's bigger than that. It's also about how do we actually do it, because we've got funding coming from federal and we've got state-based funding. We have to find a way to bring that funding together. So that brings us a national perspective. So where, as much as possible, where we can start to align that from a learning perspective, I think will be a benefit to all of us, because we're not that different. And the only other thing that I would say from a patient, from a consumer perspective, now is the time to really understand what living with illness means to patients and families, truly understanding those patient journeys, because now's the opportunity we have to build it into our systemic way of dealing with them. And I think it's such a beautiful opportunity we have now. It's just a case of really nutting through the house. So that, and even if we do it a little bit at a time, that's okay. And even if we make mistakes, that's okay too. But we need to aspire to something bigger. And I think that's a really exciting place.
Thanks, Layla. I love the concept of a learning system, and I think we underestimate, doesn't matter whether you're talking about digital health strategies, 10-year primary healthcare plans, serious investment in implementation and change management, because that's what we're talking about, is a sort of a budget line item in itself, isn't it? And really important not to forget about. I might just take one more question. But just preface this by saying we will work offline. We've got several questions, great interest in the data and the presentation, Suzanne. So we'll work offline with Suzanne to try and get a Q&A sheet out to you, clustering those questions up into some answers, because we're not going to get to them all. So a final question to you, Suzanne, from George, and then I'll just close off because we're coming up to 11 o'clock. I note 80% of the group had good or better health. Was there a sub-analysis of those with greatest healthcare needs?
So not to dodge the response, we're just currently analysing that type of data. The problem what you've got when you start to look at those types, although we've got a big data set, when you start to drill down, your numbers become smaller, so you don't see as much significance. So you've not got the statistical power. So we are looking at that. We haven't actually got anything to show currently. And as I say, I think the numbers might be a bit too small to say anything with confidence. So when you talk about significance, it's about confidence. So we don't want to overestimate, but I think there is definitely something worthy in looking in that beyond this survey.
Great. Well, look, we're coming up to 11 o'clock and we did only advertise for an hour. We could fill up a whole day in a conference on this topic. We really could. Suzanne's presented the headline results. We've had some top line reactions from our expert panelists. To answer the question that was in the chat about report availability, we'll be sharing the slides from the presentation and the recording to all of those registered. There were over 320 people registered, so they'll get the recording. We'll be publishing very soon what we're calling place cards, some summary place cards that have been developed that capture the results on a website and a policy brief. All of this work, there's a rapid review that Suzanne mentioned or may have mentioned already available, developed by the consortium on the CHF website for this project, for the Reimagining project, landing page on our website. But the culmination really will be a white paper that'll be published in early 2022. And obviously a series of academic publications that are in development, quite an active program of academic publication as well. So there will be many products and reports, both academic and in the grey literature, that you'll be able to read over the course of early 2022 arising from the project. So I'd like to thank our panellists very much for your time and engagement today, but particularly Suzanne and your amazing team at Curtin who have really worked phenomenally to design the survey with consumer input and to do all the work on the analysis.
Can I just say thanks, Leanne? Can I just say that actually very much a joint effort. So thanks to the Consumer Health Forum and our other partners. But what I didn't say, which was very rude of me, is to thank the consumers who may be online that took part in, especially the kitchen tables and our hosts. And a big shout out for Joe, Ruth and for Julia for their hard work from the CHF perspective.
Fabulous. Okay, on that note, we will bid you farewell. Happy Christmas, happy holidays, and thanks much again. Thank you.
Thanks all. Bye-bye.